Welcome back to episode 4 of our series on advanced cardiac resuscitation. I'm Ginger Locke, and I'm here with Kevin Joles, the Division Chief of EMS for Lawrence Douglas County Fire and Medical, and Joe Powell, who's the Emergency Medical Services Coordinator for the Rialto Fire Department in Rialto, California. These two services figured out how to make this work in two very different cities. There was one in Rialto, California, one in Lawrence, Kansas. How did they connect? Kevin, did Joe find you or did you find him?
We kind of found each other through one of our mutual partners in Zoll. We have some friends within our Zoll family that we were able to get a good connection. We were talking to them about wanting to change our approach to cardiac arrest and do better here in Lawrence and be able to come up with something better than what we were doing. And so moving forward, our partners in Zoll introduced Rialto Fire Department and ourselves, Dr. Caleb Trent, that's our medical director. And from there, in January to March, we had talked nearly every single week, developing our protocol and engaging all the folks that we needed to engage to ensure that we had a strong understanding of what they were doing. And this just wasn't something that we were just going to say, let's just give it a shot and see how it goes. We really carefully dissected everything with Joe and Chief Grayson out there. And as quickly as we developed our curriculum, we developed a friendship. And it's been several years now that we've been able to stay in touch and we talk often.
I'm glad that you found each other. And it sounds like what you're essentially saying, and we'll talk about this more is another time, is that this is reproducible. This is something that isn't geographical or specific to one system. So over time, the EMS profession has seen the expanded use of waveform capnography. It's my favorite vital sign, as it gives us a good indication of how the patient is metabolizing, how they're ventilating, how they're perfusing. We all kind of know it's the standard for continuously confirming advanced airway placement, but can you tell us more about how capnography is used in advanced cardiac resuscitation?
Sure. So we've talked a little bit about, or we'll talk a little bit more about going further into the program, about capnography being an indicator on when to give medications, when to strategically use electricity on the patient, and when the appropriate time to do other procedures is. And with this ACR program, like you said, unexpectedly, capnography has become one of our favorite vital signs. It's something that we pay attention to more than even chest compressions, because chest compressions goes away once we've got them on the auto pulse, and it's something that we don't really have to think about, and it's kind of an afterthought as long as we know that machine is working. Or if we were unable to put them on an auto pulse, that we're manual CPR is being done adequately because we're using the puck and getting immediate feedback. So when we are doing quality CPR, capnography is usually very receptive to that, and we're getting really good end tidal numbers, as well as how we operate when we arrive on scene. Obtaining that end tidal early on in the cardiac arrest is of utmost important to us, and we're able to achieve that probably a little bit differently than others are doing it. But we're dropping an iGel or holding the mask on the patient with the BVM along with the rescue pod, the ITD, and really getting that end tidal so that we can see if it is strategically appropriate to shock that patient right away, or if we need to prime that heart a little bit better using the mechanical or manual CPR. If we're paying attention, as we should be throughout the cardiac arrest, at any given time, the patient can or should achieve ROSC. And with the achievement of ROSC, the end tidal is going to spike dramatically, and that's going to be an indicator that we don't have to stop and feel for a pulse. If the ROSC is achieved and we've got a pulse, that end tidal is going to drive up. We're going to be able to continue CPR for another 2 minutes, evaluate the vital signs as a whole, SpO2 as well. If we can see a rhythm while we're using the mechanical CPR device or manual CPR device, we can evaluate that. That makes us not have to ever stop if we don't have to, or inadvertently stop. And using that capnography has been tremendously advantageous for us. We use it also near the end, or if we're finding that we're not seeing any increase in capnography, if we're staying down in the 15s or the low or high teens, if we're not seeing anything increase with the end tidal, then we can start to consider discontinuing CPR.
And I think, Kevin, on top of that, we're using it to make a transport decision, and how long do we stay on scene decision. So for us, with an end tidal CO2 of over 15, we'll stay on scene for 30 minutes, right? That's our mandate, for a couple of reasons. One, we initially saw that we were not getting our asystoles back until about 25 minutes into the code, which was interesting for us. And we looked at the end tidal CO2 trends, and those patients had end tidal CO2s of over 15. And so we stay on scene for 30 minutes with that end tidal CO2 of over 15. And actually, with our asystole patients, we went from a ROSC rate of 23% to a ROSC rate of 42% just by staying on scene for 30 minutes. So you get a little bit of cultural pushback saying, hey, what are we going to do? Sit on scene? We should go to the hospital. We should go to the hospital. We should go see the doctor. But first off, when you call the base hospital, they're going to tell you you should transport the patient, right? So what we've done is we don't call the base hospital until after we're en route, so you don't get that situation. But so as you get that cultural pushback, the way that we explain that process is simply, who has a better ROSC rate, us at Rialto Fire or the hospital? And that's not a very pleasant thing. I don't want a lot of friends and influence people kind of thing, right? But I have almost double the ROSC rate that the hospital does. So why would I take a patient, and we know that when you transport, we know that compression fraction goes down, we know that monitoring the patient goes down, that all kinds of things get worse when you transport. So I want to get it done right here, right now, right? Why would I take a patient and decrease their level of care, put them in an ambulance, risk my citizens' lives, risk my guys' lives to take them someplace that's half the ROSC rate? I'm not going to do it. We're going to stay on scene for 30 minutes and get those patients back. And especially those asystole patients that we would have either transported or called relatively early in the code, we stay on scene for 30 minutes and work them up based on that end tidal CO2 number.
When we started the protocol change several years back, our asystolic ROSC rate went up to 31%, and we were seeing those end tidals driving up. They were late in the cardiac arrest, but in the past, we had only been working cardiac arrest for maybe 15 to 18 minutes, and that was including transport time. So we had started the arrest, got them on the autopulse, or did manual CPR in the back of the ambulance, took them to the hospital, and we were a total combined spent time with patient maybe 18 to 23 minutes. Now what we're finding is staying on scene and paying attention to that capnography, that we're in the 26 to 29 minute mark where we're seeing a lot of ROSC. And not a lot, but 31%. 31% is a lot better than zero. And so capnography has been a huge indicator for us, especially in asystolic patients.
Yeah, same thing, Kevin. When we go back and look at the data and we use case review and we follow the data, we have to have 12 to 15 minutes of continuous compressions, continuous, without any interruption before we get anything close to ROSC back. If we stop, if we pause to check a rhythm, or we pause to intubate, or we pause to do anything, we start that clock over again. We need another 12 to 15 minutes of continuous compressions. It's got to be continuous compressions. And so we see that same basic trend.
Thanks, guys. And Joe, can you tell us about what you're doing with epi? Everybody's talking about epi and cardiac arrest. It sounds like you're deprioritizing epi in the order of interventions.
Yeah, absolutely. So we all know that epi saves lives, right? That drugs save lives and paramedics save lives, except that's not the case, right? We've got to look at the data. We've got to make decisions based on what's doing the best thing for our patient. And epi's not that, right? If you look at the study that came out of the UK maybe 6 months ago, maybe 6 months, 10 months ago, a study of over 8,000 folks, and they said clearly that they had their ROSC rate was significantly higher with epinephrine. Significantly higher with epinephrine. Okay, then give epinephrine early and often, right? That makes sense. Except the second caveat in that study is that significantly more patients had severe neurologic impairment in the epi group. Okay, then nobody gets epi, right? Nobody gets epi. Nobody gets epi. Let's stop giving epi altogether. But maybe that's not the case. So and maybe there's a sweet spot. So first off, let me tell you that there is the sweet spot is not when you first get on scene, when you're doing crappy CPR, your patient doesn't have a rescue pod, doesn't have a mechanical CPR device, or not in a heads-up environment, and the ICP is through the roof. That is not when you give epinephrine. You're going to fry a ton of cells giving epi at that point. You want a well-oxygenated, a good pH brain. You want to decrease ICP by all of the means that we've decreased ICP, proper ventilation, a rescue pod, heads-up CPR, right? All of those things that we're doing to decrease ICP. Then maybe you want to give epi. So let me give it to you this way. I'm going to give you 2 caveats, Ginger, right? And I'm going to let you choose. So if I'm going to give you the caveat that no matter what, we're going to get ROSC on your mother, your brother, your husband, your children, whatever, right? I'm going to give you the caveat that you're going to get ROSC no matter what. And I'm going to let you decide whether you want to give epi or you don't want to give epi.
Okay.
You tell me whether you want it.
So I'm going to get ROSC either way, then I don't want it.
You don't want it. Okay, I agree, right? If you're going to get ROSC, the last thing you want to do is give epi and possibly fry a bunch of brain cells.
Mm-hmm.
So let me ask it the other way. I'll guarantee you can choose epi or no epi, but you will not get ROSC without epi.
Okay.
You want the epi?
I want the epi.
You want the epi, yeah, because people that don't get ROSC have really bad neurologically intact survival, right? Right.
Right. Yeah.
Yeah. So it isn't that we never give epi, and it isn't that we always give epi. We have to give epi to the right patient at the right time after optimizing ICP, cerebral perfusion, drainage out of the brain. So what we've done, and our local EMS agency says we have to give epi as soon as we establish vascular access. So if you look at our wheel of survival, we establish vascular access the very last thing we do, right?
Mm-hmm.
So we've optimized because it's got the least amount of benefit to the patient. So it's the last thing we do, establish vascular access. I know it's, we're paramedics, we have to start IVs, right? It's like a priority for some reason because IVs somehow save lives, but that's not the case, right? We do everything else in our wheel of survival. We do all of the tools, and the very last thing we do is establish an IV and give epinephrine, which puts us somewhere 12 to 15 minutes into the code, so that we've optimized everything before giving the epinephrine. That's how we do it.
And now let's hear from Dr. Holly discussing the current science of epinephrine use in sudden cardiac arrest.
Well, I'll be happy to try. I'll have to say that the data around epinephrine is really kind of confusing right now. I think what you're hearing, though, in regards to best practices right now is really about 2 things, and that is the utilization of end-tidal CO2 as a great physiologic marker for better perfusion is vitally important. And I think the part of the reason that the studies around epinephrine have been so confusing is that we have trouble making all the other things the same so that we can really compare when we dose epi and how much epi we give, et cetera. So, for example, there are a number of studies that have not shown a great improvement in outcomes with epinephrine. There was a huge study in England just a few years ago that showed a short-term benefit in that a significantly larger number of patients survived to hospital arrival and that sort of stuff, but actually virtually no difference in patients who were discharged from the hospital, particularly those who were discharged neurologically intact from the hospital. And as a matter of fact, many of those that got significant doses of epinephrine actually did worse in that study. So it's quite confusing. There's some data out of Australia that suggests that epinephrine late in an arrest is not beneficial and may actually worsen outcomes there as well. So I think it's back to what we said initially, which is the data is pretty confusing to us. But I think one of the things here that's really important is to look at some of the animal studies around perfusion and the impact of good quality perfusion related to the use of a drug like epinephrine. And what I'll tell you in summary is that we have done CPR on a porcine model that's been in cardiac arrest for 35 or 40 minutes. About 20 minutes of that have been getting very high quality CPR with end-tidal CO2s that are near normal and very high perfusion based on other parameters. And have noticed in that animal model that a very small dose of epinephrine, half normal dose of epinephrine, followed by a shock, results in ROSC more than 80% of the time, and the majority of those animals actually are neurologically intact. And so I think part of what we are beginning to understand is that epinephrine probably has some benefit in cardiac arrest, but that perfusion is the best drug we have. Very high quality perfusion puts or sets the body into a physiologic state where epinephrine can actually be a bit more effective, perhaps, and to perform the functions that we hope epinephrine performs. So, for example, part of what we've seen is, or part of current thinking around epinephrine is that it may be less about the stimulation of the heart and the roughening of a fine VFib to a coarse VFib so that we're more likely to defibrillate them. And the improvement may actually be coming from a peripheral vasoconstriction from epinephrine, which is forcing more blood into the central circulation, resulting in better perfusion, and therefore resulting in a higher probability of a resuscitatable rhythm in a neurologically intact survivor. So I'll just sort of end this by saying epinephrine remains a bit of an enigma right now, but that the best drug we have out there is perfusion. So good quality CPR and all the things that we've been talking about today are what really make a difference in cardiac arrest outcomes.
So you've been walking down this road for quite some time now. I'm curious where you are. If we just took a snapshot today, how would you say this is affecting your cities today? Exactly, you know, what are your numbers? What's the community experiencing right now as a result of all your efforts?
Yeah, Ginger, I think, you know, when you look at our numbers, we kind of started out at about 23% ROSC. We implemented the rescue pod and the auto pulse. We went to about 40%. When we implemented all of our tools, the whole bundle of care, the whole advanced cardiac resuscitation toolbox, we're at 60% ROSC. So, and that's all comers. That's regardless of rhythm. That's regardless of downtime. That's regardless of if it was witnessed or not witnessed. That's all comers. 60% ROSC across the board. We do, you know, if you look at Utstein numbers, and I'm, you know, always happy to tout Utstein numbers, except that's a really small percentage of our population, right? We got to save everybody, not just the Utsteins, but our Utstein number is somewhere around 83%. Overall neurologically intact survival, we're in excess of 18% neurologically intact survival to discharge. Kevin?
So when we started this program about 2.5 years ago, we were at 36% ROSC, and we were kind of measuring the all-comers as well at that time. And we were unknowingly doing that. We hadn't joined the CARES registry. We weren't really following the Utstein protocol, and so we were at 36%. And the remainder of the year, which was 8 months after we did the education, we went from 36% to 63%. And as time has gone on and we've adapted and we've changed, and the numbers have increased in cardiac arrest or decreased depending on the year, we're running about 53 to 58%, just depends on which year. And we initially, our first year, we're at the 18% survivability as well. And we're now about 15%, but that equates to about 10 extra people still able to function, highly function within our community. Since we do have all comers and cardiac arrest sometimes involve traumatic events, we break those people out a little bit, and but we're still at 15% survivability, which is far higher than a majority of the nation.
And you know, Kevin, Ginger, those numbers are all important and they sound really good. But the bottom line is that people in Lawrence, Douglas, Kansas, people in Naperville are walking and talking. They have one more Christmas, one more birthday, one more day with their grandkids, their wife, and they're real people, right? And they're really alive today. And that's what's important. And that's what we're getting done in the community every day.
And all of the agencies, Rialto, Naperville, any agency, we attempt to celebrate those successes, and we invite those individuals to come visit the crews, and we celebrate their life and celebrate that extra chance that we're a part of, their families are a part of, and it really does motivates us to continue to work hard and create more science and create more data every day for all of our communities.
Thanks again for joining us as we completed our discussion of the tools of advanced cardiac resuscitation. Hopefully, this has inspired you to take a look at your community and how you can improve your outcomes. We want to hear your questions, and in the 5th episode, we're going to be live and on demand in the future. Send those questions to acr@zoll.com. We'll see you soon.